So, good afternoon, everyone. I am going to go ahead and get started with our introduction. So, I say good afternoon to those of you that are joining us from our time zone here in Ireland or somewhere near us. But for our speaker today, it is definitely very early good morning. This is our September installment of the HRB Trials Methodology Research Network webinar series. And my name is Simone Lepage. I am the webinar coordinator. So first of all, we were meant to have two speakers today, but I'd like to make his apologies for him. Dr. Geoffrey Curran was unable to join us, but luckily his co-presenter is with us and I'd like to introduce him. So Dr. John Fortney is a professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine and the director of the Division of Population Health. He's also a senior research career scientist at the HSR&D Center for Innovation for Veteran-Centered and Value-Driven Care at the VA Puget Sound Healthcare System, and multiple principal investigator of the Virtual Care Query Program. So Dr. Fortney will be speaking to us today about the similarities and differences between pragmatic trials and hybrid effectiveness implementation trials. And he's also going to offer practical recommendations to help investigators to properly select, label, and implement the most suitable trial to address their research question. So I will go ahead and let him get started. And I would like to remind everyone that we are recording this and we'll post the PDF of the presentation when we post the recording. If you have questions, you can pop those into the Q&A box or the chat box, and we'll try and address those when the webinar is finished. And there are also auto-created closed captions, and you can turn that on. There's a button at the bottom of your screen if you so wish. So thank you very much, John, and very good morning to you.
Thank you very much. Let me introduce my colleagues who helped me work on this paper, specifically Jeff Curran, and Jeff does apologize for not being here. He had a death in the family yesterday. He is at the College of Pharmacy, University of Arkansas for Medical Sciences, where I was for many years, and the University of Limerick. I have also a colleague, Lyon, from the Department of Psychiatry at UW, Devon, who's in Population Health Sciences at Duke University, and surgeon David Flum from the University of Washington. We have no conflicts of interest to report, though we do have a number of grants from different agencies. The first is the Patient-Centered Outcomes Research Institute, or PCORI, which was developed as a part of Obama's Affordable Care Act, and they fund only pragmatic trials. We have funded by a number of NIH trials, and as well as VA query trials. Query is the implementation science arm at the VA. I will note that the views expressed here are those of us and not of the VA, NIH, or PCORI. I'm a much better writer than speaker, so you could leave the presentation and go read the paper. It is listed here. It has more detail than I'm going to get into. Be able to get into in the presentation. So let me start out with a couple of definitions so we're on the same page. This first distinction might be obvious, but it isn't always. So clinical interventions are treatments like psychotherapy, treatment modalities like mHealth or eHealth, service models like patient-centered medical homes that are designed to, an important word here, directly impact patient outcomes. Implementation strategies promote the uptake of evidence-based clinical interventions and indirectly impact the patient outcomes. We absolutely acknowledge that the distinction between clinical interventions and implementation strategies is sometimes blurred, especially with regard to interventions designed to promote patient engagement in treatment like telehealth. But for purposes of this presentation, we'll assume these are separate things. Two more definitions here. One is by Thorpe et al., who say that pragmatic trials are primarily designed to determine the effectiveness of a clinical intervention under the usual conditions in which it will be applied. And my colleague Jeff Curran defines a hybrid effectiveness implementation trial as one that has a dual focus a priori in assessing clinical effectiveness and implementation. So in the context of bench-to-bedside translational research, the difference between explanatory clinical trials, also known as efficacy trials on the left-hand side of this graphic, and pragmatic trials, also known as effectiveness trials, in the middle of this graphic, is pretty well understood. Explanatory trials are designed to answer the question, can this intervention work under ideal conditions? In contrast, pragmatic trials are designed to answer the question, does this intervention work under routine care conditions? Acknowledging that most trials are not purely explanatory nor purely pragmatic, the PRECIS tool provides guidelines for describing where on the explanatory pragmatic continuum a trial falls. On the other end of the translational research continuum on the right, the differences between pragmatic trials and implementation trials is also well understood. Pragmatic trials test the effectiveness of clinical interventions by comparing. Implementation trials test the success of implementation strategies designed to promote the use of evidence-based practices previously demonstrated to be effective in routine care. Implementation trials are designed to answer the question, does this implementation strategy successfully promote the use of the evidence-based practice in routine care? The primary outcomes of implementation trials typically include things like how many providers adopted the EBP, whether providers delivered the clinical intervention with high fidelity as intended, and how many patients were reached or received the evidence-based practice. To speed up the process by which EBPs are developed and adopted, Geoff Curran et al. Encouraged researchers to consider using hybrid effectiveness implementation trials. So by conducting one hybrid effectiveness implementation trial instead of two sequenced pragmatic followed by implementation trials, the bench-to-bedside timeline can be shortened. And the differences and similarities between pragmatic trials and these hybrid trials are not well understood. And there are basically three types of hybrid trials shown here on the bottom of this graphic. Hybrid type 1 trials primarily assess the effectiveness of a clinical intervention or interventions while exploring the barriers to implementation and potential strategies to overcome those barriers. So that's on the left-hand side of the triangle. On the right-hand side of the lower triangle, hybrid type 3 trials primarily assess the success of implementation strategies while secondarily examining the effectiveness of the clinical intervention being implemented. And in the middle there, the complicated ones, the hybrid type 2 trials place roughly equal importance on comparing clinical interventions and the implementation strategies. Geoff actually specified two different types of hybrid type 2s. A dual randomized type, where two or more clinical interventions and two or more implementation strategies are compared simultaneously. That's really hard to pull off. Those are called hybrid type 2Bs, and a pilot type where two or more clinical interventions are compared with one implementation strategy being evaluated. That's a type A. So these three types of trials test the effectiveness of clinical interventions: pragmatic trials, hybrid type 1 trials, and hybrid type 2 trials. And these two trial types test the success of implementation strategies: hybrid type 2, where the type B are comparing two clinical interventions and two implementation strategies, and hybrid type A, which compare two clinical interventions and one implementation strategy, and the hybrid type 3s. So the purpose of this presentation is to clarify the similarities and differences between the pragmatic trials and hybrid trials, both for funders, researchers, and policymakers, acknowledging that most trials are not pure pragmatic trials nor pure hybrid trials. Blurred boundaries between these trial types can hamper the evaluation of grant applications, the scientific interpretation of findings, and policymaking. To illustrate this, I want to highlight a recently published paper from a PCORI-funded trial, self-labeled Pragmatic Clustered Randomized Controlled Trial of integrating behavioral health into primary care. This trial recruited 42 primary care clinics from 13 states and consented 3,000 patients with chronic physical health and behavioral health disorders. It was a very large, very expensive trial. The comparators, called interventions in the papers in this trial, are described as co-location of mental health specialists in primary care versus co-location of mental health specialists in primary care plus an online educational curriculum for providers, implementation workbook, remote quality improvement coaching services for internal facilitators, and an online learning community. You'll notice that the clinical intervention in both arms is the same, i.e. co-location, but arm 2 has got what looks to me as an implementation strategy added to it. You'll notice that there were no differences between the two groups in the primary outcome, which was change in mental health symptoms and functioning, or the 29 other health status outcomes they had, nor was there any difference between groups in their secondary outcome, fidelity to the integrated care group. So my question for you, which I'd like you to tap in the chat or the Q&A, whichever you have access to, is to type in what kind of trial do you think this is? Is this a pragmatic trial, as it was labeled? Is it a hybrid type 1 trial, a hybrid type 2, A or B trial, or a hybrid type 3 trial? And I will say, I'm also guilty of confusing these things. I once wrote in a grant that we were going to conduct a pragmatic hybrid type 2 randomized clustered trial. And I thought the more adjectives I put on my description of my trial, the more likely I was to get funded. We did get funded, but I eventually came to the conclusion that what I wrote in that grant made no sense. So I don't want to pick on these folks too much. So type in the Q&A what type of trial you think it is. I won't be able to see it, but I would like you to look at the answers. And what I'm predicting is that there's going to be a huge range about what type of trial people think this is.
Do you want me to update you? Oh, have I not?
Sure.
Someone said, can you enable chat? But I'll do that. But we have a couple of answers. I'll let you talk for a minute, and then I'll update you when I have some more answers. And I've
okay, great. I'm going to come back to that slide, so maybe you can do a count for me when we revisit it. So let me start out by what the similarities are between pragmatic trials and hybrid trials. They almost always deliver the clinical intervention in a routine care setting, so not in a research clinic or a lab. The clinical interventions are delivered by routine care providers, not by the PI or one of their grad students. There are usually broad inclusion criteria that are assessed maybe mostly with the EHR or a couple of simple questions that are routinely used in clinical settings. There are minimal exclusion criteria. So you're not getting rid of patients with comorbidities or inability to adhere to treatments. Fidelity is almost always measured and reported, and there are intent to treat statistical analyses. So everybody enrolled is included in the analyses. The greatest similarities are usually between the pragmatic trials and the hybrid type 2 trials, because they are both designed to measure the effectiveness of clinical interventions, which previous research has shown to be effective, at least in some population settings and delivery modalities in the past. So that's where the confusion usually arrives. However, there are 6 main types of differences between trial types, and I'll go through each of these in turn to clarify what I mean. What is specified as the primary outcome, the specification of the implementation strategies, how they're specified, the secondary aims of the study, aims 2 and 3 of your grant applications, attention to fidelity. In some terms, I'm going to describe whether the implementation strategies are artificial or practical, and whether the implementation strategies are evidence-based or novel. So let me go through each of these in turn. So pragmatic trials, along with hybrid type 1 and type 2 trials, compare the effectiveness of 2 or more clinical interventions. And therefore, Their primary, or in the case of HD2s, that's hybrid type 2, co-primary outcomes are usually patient-level outcomes of health status. So things like treatment adherence, procedural complications, side effects, lab results, symptoms, functioning, hospital readmission. Hybrid type 2 and type 3 trials compare two or more implementation strategies, and therefore their primary, or in case of HD2, co-primary outcomes are usually specified as things like provider adoption, provider fidelity, patient reach. Hybrid type 2 trials are expected to specify patient-level health outcomes as secondary outcomes because the implementation strategy being assessed as a primary outcome only indirectly affects patient health. So how about the specification of implementation strategies? Because hybrid type 2s and type 3s are evaluating the success of implementation strategies, often hypothesizing that one is superior to the other, the implementation strategies are always pre-specified in grant applications, trial registries, protocol papers, and are described in detail in the result manuscript. For example, those who are familiar with the ERIC terminology might use one of those descriptors for the implementation strategies. ERIC is described in the PAL paper, the bottom of the slide. However, historically, the implementation strategies of most pragmatic trials and hybrid type 1 trials are not pre-specified, meaning they're not reported before publishing the results, and often not post-specified in the results papers. And if they are, as one of Jeff's colleagues has pointed out, Sarah Landis, they're not usually called implementation strategies in the grants or protocol papers. They might be labeled under a section called provider training and supervision. So all pragmatic trials and hybrid type 1 trials have a way of supporting the correct delivery of the intervention with high fidelity, but they're often not really described very well. And specifically, as I'll discuss a little bit later, the lack of pre and post specification of implementation strategies can really make it difficult to distinguish between the pragmatic trials and the hybrid type 1 trials. Another difference between trial types is whether moderation or mediation analyses are specified as secondary outcomes. Moderation analyses test interaction effects, such as whether the impact of a clinical intervention depends on the characteristics of the patient. We call this treatment heterogeneity analyses. And hybrid type 2s and type 3s can theoretically conduct moderation analyses to examine whether provider clinics or organizational contextual factors are effect modifiers for the implementation strategy, but such moderation analyses are much less common in hybrid type 2s and 3s because there are usually a small number of providers, clinics, or organizations that are being randomized in most trials, which creates inadequate statistical power. So you almost always see these in pragmatic trials and hybrid type 1 trials, but rarely in a hybrid type 2 or type 3. Mediation analyses determine how a clinical intervention is improving patient outcomes through what clinical mechanism. So for an antidepressant, it would be some brain chemical that's actually changing. And these are often conducted in hybrid type 1 trials and are always conducted in efficacy trials. Mediation analyses are not typically conducted in pragmatic trials because the mechanisms of action for the clinical intervention have usually already been well identified in the explanatory trials. Hybrid type 2B and 3 trials also determine how an implementation strategy is promoting uptake through what implementation mechanism, like increase in knowledge. An example of this is a hybrid type 3 trial conducted by Williams et al. That randomized 475 mental health clinicians and 14 children's mental health agencies to a usual implementation or to a novel implementation that improved organizational culture. Results demonstrated that organizations improved, that the organizational improvement implementation strategy was significantly substantially increased the uptake of EVPs, and that as hypothesized, improvements in organizational culture mediated the effect of the implementation strategy on uptake. So mediation analyses are rare in pragmatic trials. They're not unusual for the hybrid type 1 and type 2s, and they can be done with regard to implementation strategies, and they're strongly encouraged for hybrid type 2s and 3s. So we're understanding how the implementation strategy is working, or is more often the case, not working. The implementation outcomes of adoption and reach are frequently specified as primary outcomes in hybrid type 2 and type 3 trials, but are rarely measured and reported in pragmatic trials or hybrid type 1 trials. However, the implementation outcome of fidelity isn't so straightforward. Fidelity represents the degree to which the clinical intervention is delivered as intended. It's fine to make adaptations, that's encouraged, which deliberately fidelity consistent changes to the adaptable periphery of the clinical intervention to improve fit, engagement, and effectiveness. So tailoring it for a certain culture, that's totally encouraged to promote adoption or to promote reach. But we want to discourage deviation from the core intervention components. So how we deal with this in the different type of trials is very telling. A fundamental difference between pragmatic and hybrid trial types concerns the role of fidelity. So the degree to which the core intervention components are delivered as intended. So the difference in the trials depends on whether fidelity is intervened upon at all, and if so, how fidelity is intervened upon, how much fidelity is intervened upon, whether it is that fidelity intervening is pre-specified, if fidelity is reported as a descriptive variable, or whether it is analyzed as a dependent variable. Because the purpose of pragmatic trials is to estimate the effectiveness of clinical interventions in routine care, fidelity is reported descriptively, like hybrid type 1s, but not intervened upon more than a healthcare system normal quality improvement activities. In fact, the PRECIS tool rates how pragmatic a trial is based on how much fidelity is controlled by the investigators. So hybrid type 1s can intervene on fidelity as much as needed, and they often use artificial strategies. And I'll talk about what I mean by that word artificial. They may or might not pre-specify those strategies, and they report them descriptively. Pragmatic trials intervene on fidelity using practical evidence-based strategies. I'll define both those terms in a minute. They usually do pre-specify those strategies in grant applications and protocol papers, and they, like hybrid type 1s, report fidelity descriptively. In contrast, hybrid type 2 and type 3 trials test the effectiveness of a novel implementation strategy designed to maximize fidelity. So they intervene on fidelity using practical novel strategies, not practical evidence-based strategies. They always pre-specify those strategies because there's a hypothesis associated with them. And fidelity is often analyzed as a dependent variable. So for example, there's a trial by Monson et al., which conducted a hybrid type 3 trial that compared fidelity to a protocolized psychotherapy for PTSD across 3 groups of therapists randomized to different implementation strategies: training with no consultation, training plus standard consultation, and training plus consultation involving audio review of selected therapy sessions. They found no differences in fidelity. The dependent variable fidelity assessed by the independent raters were observed across the 3 groups, suggesting that augmenting training with consultation is not effective implementation strategy, at least not in that context. Okay, so next I'll discuss what I meant by the terms artificial and practical that I used in the previous slide. Artificial implementation strategies are those that are not feasibly replicated in routine care settings without additional research dollars supporting them. Examples would be adoption is artificially increased by using research funds to pay for intervention delivery. So you hire graduate students to deliver the intervention, or you hire clinicians to deliver it. Another example would be reach is artificially increased by advertising the community for trial participants, radio ads, flyers on telephone poles. Third example would be fidelity is artificially increased by monitoring fidelity frequently and then retraining clinicians with poor fidelity or firing them all together, and taking them out of the trial. So hybrid type 1 trials are more likely to use these artificial implementation strategies while exploring the more promising practical implementation strategies. Often a hybrid type 1, the third aim of your grant will be to explore barriers to care and potential practical implementation strategies. So an example of a hybrid type 1 trial with some artificial implementation strategies is a tobacco treatment in an oncology center trial conducted by Ghosh. And they report a week-long training for study counselors, followed by investigator reviews of counseling session recordings, weekly supervision meetings to review all active cases to optimize fidelity. So that's pretty artificial. You would never have that happen in routine care. But after the trial's over, they're going to use focus groups to assess what more practical implementation strategies for the intervention might be. Pragmatic trials, hybrid type 2 trials, and hybrid type 3 trials need to use practical implementation strategies to ensure external validity, meaning that the results are generalizable to the healthcare system that wanted to adopt the EBP, because they're not going to have research funds to prop up the implementation. Pragmatic trials mostly differ from hybrid type 1 trials because they rely on more practical implementation strategies rather than artificial ones. And this is why hybrid type 1s, but not pragmatic trials, need to conduct the exploratory research to identify the practical implementation strategies. And as I said, when the implementation strategies used in hybrid type 1s and pragmatic trials are not well described, it's difficult to tell the difference between them. So just like, let me turn to what I mean by novel versus evidence-based implementation strategies. Just like clinical interventions and implementation strategy can fall along the continuum of evidence-based to novel. So a novel implementation strategies are one they're not known to be effective in what's the context they're being used. That's why we're testing them in a hybrid trial or implementation trial. Evidence-based implementation strategies are known to be effective in the context of which they're used. Now, to ensure high fidelity delivery of the intervention, pragmatic trials should use evidence-based implementation strategies to ensure that the two interventions being compared are being delivered with high fidelity and are improving patient care. Or there should be comparing treatments that don't really require implementation support. So, for example, that might be my colleague David Flum, the surgeon, compared antibiotics to surgery for appendicitis, both of which have been already adopted into routine care with high fidelity. He didn't need to have much implementation support on that. Many hybrid type 2Bs and hybrid type 3s compare a novel implementation strategy to a commonly used implementation strategy known to be marginally successful, so like train and hope, or train and pray, as we say in psychiatry. So you're comparing what you hope is a better strategy to the one that's currently used. So for example of that hybrid type 3 trial, Michael Couture, in a randomized psychotherapist to a standard training in cognitive behavioral therapy, evidence-based practice for depression and anxiety, or standard training plus computer support. That's the novel implementation strategy. Therapists randomized to training plus computer support were substantially more likely to follow the therapy protocol with fidelity. That was their primary outcome. And their patients experienced statistically greater improvements in symptoms. That was their secondary outcome. Hybrid type 2B and hybrid type 3 trials can also compare a novel low-intensity, low-cost implementation strategy to a more resource-intensive, higher-cost implementation strategy that's known to be effective. So you're not always comparing an implementation strategy that you think is going to be better. Sometimes you think one it's going to be equally as good and cost less and be easier to implement. Okay, with that all behind us, we can look at what determines what type of trial it is. Acknowledging the trial types fall along a continuum, the differences between these trial types can be documented according to the following dimensions: the primary outcome, attention to fidelity, use of artificial versus practical implementation strategies, and use of evidence-based versus novel implementation strategies. The moderation versus mediation analyses can also be used to identify trial types. So here we go. Hybrid type 1s. The primary outcome is almost always patient-held status. Fidelity is measured and described in the paper. Fidelity is intervened on using non-specified, often, artificial strategies. So whatever it takes to make sure that there's high fidelity to the intervention so that you can determine whether your intervention is more clinically effective than the comparator. Sometimes those strategies will change over time as you discover that fidelity is not so hot. It's okay. And they often do mediation analyses to determine whether the clinical mechanism of action, the hypothesized one, is actually the thing that's improving outcomes. Or if outcomes were not improved, whether it was because that mechanism was not successfully targeted. Pragmatic trials, the primary outcome is again patient health status. Again, fidelity is measured and described. But fidelity, in contrast to the hybrid type 1s, is intervened on using pre-specified practical and evidence-based strategies. So these are things that are known to be effective and that the healthcare system could use for scale up. And they usually do moderation analyses looking at patient heterogeneity. There are certain subgroups in the population that aren't doing as well as others. Hybrid type 2s and type 3s, the primary outcome is implementation success, and patient health for hybrid type 2s is a primary outcome. Fidelity is often a dependent variable, not just a descriptor. And fidelity is intervened on using pre-specified, practical, but in this case, novel, not evidence-based strategies, because you're testing whether the novel strategy is better than the currently used one. And mediation analyses are strongly encouraged to identify the implementation mechanism of action. So, Simone, here's where you can help me out. Let's investigate this, re-examine this, this clinical trial that I mentioned before. It looks like there's a number of things in the chat. What are people saying that this type of trial is?
Well, I had to get my whiteboard out for this one because I was trying to keep track of the chat and the Q&A and not count anyone double. And I'm probably, I don't know if people have changed their minds, but anyway.
Wait.
We had 2 that just said hybrid,
Okay.
1 that said hybrid 1, 5 that said hybrid type 2, 3 that said hybrid type 2B, 5 that said hybrid 3, and 2 that said pragmatic.
That's awesome. That's exactly the results I wanted. Okay, so because there's one intervention, it's not a pragmatic trial or a hybrid type 1 trial. Those type of trials compare 2 clinical interventions. So I'm thinking this is from that, this is an implementation trial or a hybrid trial. But the primary outcome is patient health status, which only indirectly is impacted by the implementation strategy. So the answer is that this design doesn't really answer any meaningful scientific question in my mind. If the outcomes, the primary and secondary outcome, were flipped, and the primary outcome was fidelity to the integrated care model, and the secondary outcome was change in patient health status, I think this would be a hybrid type 3 trial, because it's basically comparing the implementation strategy to essentially no implementation strategy. But that doesn't make this trial necessarily well designed, because this trial was powered on the primary outcome, which was patient mental health symptoms. So it wasn't powered in the right way to examine fidelity. So I think this trial was kind of a waste of a lot of money.
So you tricked us.
I did trick you, sorry. The paper includes this little tool to help you identify what type of trial you're looking at. So the first question on this little tree is, are any of the implementation strategies artificial? And if the answer to that question is yes, then you're looking at a hybrid type 1 trial. If the question is no, you can go to the next question, which is, are all implementation strategies evidence-based? And if the answer to that is yes, the next question is fidelity being controlled? And if the answer to that is no, then that's a pragmatic trial. You're comparing two clinical interventions with evidence-based practical implementation strategies, and you're not artificially controlling fidelity. So that's a pragmatic trial. If it's evidence-based implementation strategy and fidelity is not being controlled. If fidelity is being controlled, that's really a suboptimal design. It's not answering any important scientific question. However, if the implementation strategies are not evidence-based, or at least in one arm they're not, is a measure of clinical effectiveness a primary outcome? In that case, if the answer is no, that's a hybrid type 3 trial. If a measure of clinical effectiveness is a primary outcome, the next question is, are two or more clinical interventions being compared? The answer to that is no, then that's again a suboptimal design, and that's the design that the example I just gave was. There was only one clinical intervention being compared. But if two or more are being compared, the answer to that is yes. And the last question is, are two or more implementation strategies being compared? The answer to that is yes, that's a hybrid type 2B, and if no, it's a hybrid type 2A. So hopefully you can find that helpful when you're doing grant reviews, or you're trying to interpret a paper, or you're trying to design your own trial. Okay, so I'm going to go on a bit of a tangent, and this is actually the tangent that kind of got us all started down this path. I'll say that while fidelity should not be controlled artificially in pragmatic trials and hybrid type 2 trials, it's uninformative and unethical to compare two clinical interventions that are being delivered with such low fidelity that patients are unlikely to experience clinical improvement. So for both pragmatic trials and hybrid type 2 trials, they must ensure that fidelity of the clinical intervention or interventions is sufficient to produce pre-post clinical improvement among patients. There's no point in comparing two poorly delivered clinical interventions that aren't improving patient outcomes. Therefore, fidelity to the core functions of the clinical intervention should be monitored during both trial types using practical methods if possible, meaning replicable outside the context of research. And when fidelity is so low that patients are not benefiting clinically, the trial needs to be rescued. We call this your trial going into the ditch. So by rescue, I mean, if possible, it should be rescued by increasing the intensity of your pre-specified practical evidence-based implementation strategies, or adding post-hoc implementation strategies, i.e. guardrails. If artificial strategies have to be used, the trial becomes a hybrid type 1 by default. And this can happen. Your trial type, if you have to change your implementation strategies midway through because it's a dumpster fire, you change your trial into a hybrid type 1. For hybrid type 2 trials, investigators must also weigh the disadvantages of making post-hoc modifications to the implementation strategies, thereby sacrificing the co-primary aim of comparing pre-specified implementation strategies to rescue the co-primary aim of comparing the clinical interventions. One way in hybrid trials to avoid this is to pre-specify adaptive implementation strategies. And in those type of trials, you specify, sometimes these end up being smart trials, is what you're going to do next if fidelity isn't achieved or adoption isn't achieved. So you can actually pre-specify adaptions or putting in guardrails in, and that's absolutely fine. Okay. Simone, how am I doing on time?
You're doing well. Might want to wrap up in the next 5 minutes or so to allow for questions.
Okay. So I want to give a couple of recommendations. And these recommendations are designed to complement the reporting guidelines for clinical effectiveness trials and implementation trials, specifically the tidier ones for intervention description and the starry ones for implementation. These are both published in the British Medical Journal. So the first one recommendation is that hybrid type 1 trials should be used to determine whether a clinical intervention can be effective when delivered in routine care. Pragmatic and hybrid type 2 trials should be used to determine whether an evidence-based clinical intervention is effective when delivered with practical implementation strategies in routine care. Hybrid type 2 and type 3 trials should be used to determine whether practical and novel implementation strategies successfully promote the uptake of evidence-based clinical interventions. In all pragmatic and hybrid trials, the implementation strategies used to ensure to intervene on fidelity should be pre-specified and classified as artificial or practical and novel or evidence-based in the target healthcare system. And if that's not clear, which it might not be in many cases, the degree of artificiality or the quality of the evidence about evidence-based should be described and discussed. And the implementation strategies used should be reported in all the research proposals, study protocols, and publications, so people can determine what kind of trial type you just did. Hybrid type 1s may and usually do use artificial fidelity monitoring methodologies and artificial implementation strategies to ensure high fidelity, but they should conduct process evaluations to explore the potential for using more practical strategies. As I stated earlier, pragmatic trials mostly differ from hybrid type 1s because they rely on more practical implementation strategies rather than artificial ones. That's why the hybrid type 1s, but not the pragmatic trials, need to conduct the exploratory research to identify practical implementation strategies. But in the spirit of hybridization and speeding up the bench-to-bedside timeline, pragmatic trials could also start conducting qualitative or mixed methods process evaluations to facilitate the large-scale rollout of clinical interventions proven to be effective in routine care. Process evaluations are currently recommended for pragmatic trials, especially for multi-site trials testing complex interventions, though the focus tends to be on documenting how well the clinical intervention was implemented in order to interpret the observed effectiveness of the intervention on improving outcomes. But pragmatic trialists might consider expanding such process evaluations to examine things like optimizing the implementability of the clinical intervention if it's found to be overly complex in the pragmatic trial, or to improve the practicality of the implementation strategy if any were determined to be artificial or overly burdensome for the healthcare setting. And 3, to identify settings that are conducive to future implementation based on observed provider level or organization level or environmental level barriers. Hybrid type 2s and hybrid type 3 trials are expected to test novel implementation strategies or implementation strategies without an evidence base in the target setting. In contrast, pragmatic trials should use practical implementation strategies that have an evidence base in the target setting. Otherwise, investigators run the risk of having to apply artificial implementation strategies post hoc to maintain adequate fidelity. Ideally, implementation strategies used to intervene on fidelity should also be pre-specified in grant applications and protocol papers, although post hoc additions to the implementation strategy may be needed if there are unforeseen barriers to fidelity. In our last recommendation, during pragmatic trials and hybrid type 2 trials, fidelity should be monitored using practical methods, and if fidelity drops below a minimum threshold, the ditch, that's expected to result in a lack of pre-post clinical improvement for patients, the research team should increase the number or intensity of practical implementation strategies to promote fidelity. So they should have guardrails. Those guardrails should be pre-specified. Such guardrails are not necessary in hybrid type 3s because clinical effectiveness is not a primary outcome. Although, as I said, similar adaptive implementation strategies may be used. So let me stop there and field some questions and maybe hear some suggestions.
Thanks, John. That was really, really educational, and I'll wait for the questions to come in. I'm going to pull my novice student card here. When you talk about like in hybrid one process evaluations, are we talking about SWOTs, studies within a trial, or just the actual process evaluation and not necessarily adding in the actual? I don't know. I'm asking from a not knowing point of view.
Right. So when you're writing aims for a hybrid type 1 grant, you might, the first aim might be to examine patient health status between patients randomized to one clinical intervention or another. Your second aim might be to determine whether the mechanism of action was successfully targeted, meaning, the therapy worked by reducing people's rumination, for example. Did their depression go down, and did rumination go down, causing the depression to go down? And the third aim would be examining barriers to fielding your now effective intervention using practical implementation strategies. So maybe you did a therapy trial that was focused on reducing rumination to improve depression symptoms, and your intervention was, normal CBT. Your comparator was normal CBT, and your intervention was CBT plus something else that was specifically focused on rumination. And you spent a week training your therapists. You taped every session with the patients. You reviewed all the sessions, and you had weekly case reviews with your therapist, telling them, you did well here, you didn't do well here, you need to improve here. And then maybe you had a couple therapists that just couldn't, follow the protocol, and you had to let them go. So you're never going to do that in a busy mental health clinic. So the question is, how could you get those therapists to achieve fidelity in a practical way? And so you might do qualitative interviews with the therapist. You might do a focus group with supervisors,
Okay.
That kind of thing. And
Okay.
that'll be your third aim of your hybrid type 1 trial, is to figure out for the next study, your hybrid study or your implementation trial, what strategies you would need to overcome the barriers to fidelity.
Okay. Thank you.
That make sense?
Yeah, it does. Thank you. Yeah, someone else had said I was thinking the same about SWOTs, but the issue is that it's usually one on improving trial performance rather than the implementation of the intervention.
I will confess I don't know what a SWOT is.
Okay, sorry, a study within a trial.
Study within a trial. Okay.
Yeah.
That's exactly what it is. Yes, that's exactly what it is.
I do have two questions there. The first one is, what are the trial power considerations surrounding HEITs? So hybrid HEITs, hybrid type 2s. Okay.
What was the question exactly?
What are the trial power considerations surrounding them?
It depends on what type, and it specifically depends on what your primary outcome is. So for a hybrid type 1, you would power on your patient outcomes, right? So, you would look at whatever your instrument was for measuring patient symptoms, what the standard deviation was, what you expect the difference between the groups is, and you power off that. For a hybrid type 3 trial, your outcomes are going to be implementation success, like were more providers in the intervention group adopting the evidence-based practice in the control group, or was fidelity higher in the intervention group than the comparison group? And there you're powering on your primary outcomes being implementation success. And that's going to be harder because there are going to be a lot more patients than there are providers, right? So you're going to need lots of providers. We just did a hybrid type 3 trial where we trained 80 therapists in a new psychotherapy. So we have an N of 80. So that was what our power analysis said we needed to use to detect differences in adoption. The hybrid type 2, that's where you run into things immediately, problems immediately, because you've got dual primary outcomes in a type B, and you have to power on both of them. So you have to say, our sample size of patients is this, we're going to have this much power to detect the difference in patient outcomes, and we're looking at, let's say, fidelity among the therapists for our implementation primary outcome, and we're going to need 50, 60 therapists to do that. So that's where when you start to do a power for a type 2, you change your mind and do a different study because you realize you don't have the budget for it.
Yeah, it does. It sounds very challenging, to say the least. I have a comment/question.
Okay.
Is it just me, or do funders more like to see a clinical outcome as primary and powered outcome? Hence, often trials are testing implementation strategies, a hybrid type 3, then they get turned into a hybrid type 2?
It depends on the funding agency. I only know the ones in the United States, but NIH wants to see clinical outcomes, absolutely. And so they don't fund hybrid type 3s for the most part.
Okay.
In the VA query, I would say half, if not more, of the trials there are hybrid type 3 trials. And in those cases, we're not even randomizing patients, so they don't end up being classified as research projects. They end up being classified as QI projects. So the answer to that is it depends on really who the funder is. And I don't know much about the funders in the UK, so maybe you guys could comment about that and inform me.
Okay. I'll see if anyone has anything to say about that.
Say the UK or Ireland. I don't know if your funding agencies are different.
We do have different, yes.
Sorry.
But also, no, that's okay. Sometimes people draw from. So I have another comment here /question. I am increasingly seeing hybrid implementation trials when I sit on NIHR, so that's the National Institute. NIHR committees, although still relatively uncommon and certainly not as clearly delineated as your excellent presentation. So question in the US, what's the status of these trials? I would guess they are common in the PCORI setting, other NIH funding. So
PCORI doesn't fund implementation science work for the most part. Okay. So they fund only pragmatic trials, which made the trial that I gave as an example even worse, is PCORI funded a trial they didn't really want to fund. NIH and the VA query, they're funding a lot of hybrid type 2s. They tend to be type A's, where someone's done a hybrid type 1, they have a clinical intervention that they think is going to be effective. They have tested it with artificial implementation strategies, and then they move to a hybrid type 2A where they're testing that maybe in a bigger sample using practical implementation strategies. You see a lot of hybrid type 2As, not very many type 2Bs because it's just hard to pull off.
Yeah. I think that's it. I'll give people a chance if anyone has anything else, and then we can sign off. I don't have a next webinar to plug, but we have our big International Clinical Trials Methodology conference here coming up, John. So that's at the end of September and the beginning of October. So hopefully I will see some of the participants here today there in Edinburgh. And Kate, just another comment. Thanks very much for a great presentation. Very helpful and clear. Lots of thank yous coming in. Excellent, concise presentation. So thank you so much, John. And I hope you have a great rest of your day. As it's just beginning.
It is. The sun came up.
Yeah. All right. Lots of thank yous coming in. So unless you have anything else, I'll let you go.
All right. Thanks so much, everyone. Appreciate the opportunity.
All right. Thanks.
Bye.
Bye. Thanks, everyone.